So welcome all. We have a few more questions to go over for this week, even though many people submitted them and accurately so figured out from the readings where the correct direction and answer was. One that will be of interest to discuss is capitation versus fee for service. There's no wrong answer in that question, so we'll talk about and love to hear your opinions on both sides of the topic. Just wanted to go over. Oh, so if you guys, again, I'm available almost like 24/7. If you have questions about the questions, you have questions about your paper, if you are not feel like you want to supplement, and again, you can resubmit your questions if you don't get the grade you want, and I'll regrade them, just let me know. Again, my goal in this class is to give you every option to succeed. And again, if you didn't feel like you had a good enough chance to participate in class, or you prefer a one-on-one, feel free to, we can set up a 5-minute Zoom and we can do a one-on-one, and that way you can augment your participation. Again, if you didn't feel like you had enough opportunity to speak and prove your understanding of the materials that have been submitted. I've gotten about half the questions for this week already. I've gotten about half the submissions for course evaluation. I'm so glad this is the first class over the past, 30 years that I've taught, to do this early so that we can intervene and make this a better experience for everybody involved. So that's awesome. And I appreciate all your feedback. Easiest assignment ever. Everybody gets 100 because whether you like it or you don't, I appreciate the feedback, and it's an opportunity to improve. Any current questions, either admin or otherwise, that we should go over? Great. And again, if you think you need more guidance in terms of the rubric or anything else, just reach out to me one-on-one. I'm happy to sort of go over it. It's basic scientific method. So in terms of standard research and scientific methods. So that's all I'm looking for. So that's great. Let's start with I'm trying to decide whether I should go over. Well, you know what, let's just do current topics, because there's been just tons of current topics and a lot of overlap, frankly. Week to week, a lot of topics that we have covered. So anybody can just speak up at any point to talk about one or two current topics they thought were of interest. One thing I would love to bring up just as an outside is we haven't talked about the earthquake in Turkey. So I'd love your thoughts on what are the public health implications of natural disasters, and specifically maybe talk about some of the issues in Turkey and Syria. Easier for me to call on people, or do you want to just speak up, and I'll just wait for all of you to say I've spoken?
I'll just go. You can just go through.
No, appreciate it. Thank you.
So on Kaiser, they posted it. They sent it out this morning. That there's a state bill being passed in North Dakota and in Wyoming that physician assistants are able to practice independently, and like they're doing skills that are like outside of their training because of the health worker shortage. And I feel like that's like not putting a band-aid on a bullet hole. That's like putting a band-aid that doesn't even like work on a bullet hole, because I feel like it's creating more problems. You're just causing a lot of issues for like the assistants as well as the physicians, because they're not trained to do that, and that's putting a lot of pressure on them that they're like not used to having to do, and they can also make a lot more mistakes and stuff like that. I feel like that's scary.
So that's a fascinating topic. I'm so glad you brought that up. We're doing a whole class on it. And I think we discussed this either Tuesday or last week. I said, yeah, we're doing a whole class on this. Our physician, our advanced clinical providers part of the solution or part of the problem? You think they're part of the problem? The AMA would agree with you. Any other thoughts on that topic of advanced clinical providers as part of the solution or part of the problem?
I definitely agree with what Sid said, like that it's like not even putting a band-aid on like a bullet hole, because we go to school to be trained in that specific practice. I mean, I guess if like they like advance the changes for like in the situation, if you are a physician assistant doing the scope of work of a doctor, it's just more, I think more training needs to be implemented in that case of a situation if it were to happen.
Anybody else? Anybody think advanced clinical providers are a good idea or could help the situation? And so much of this answer depends on the situation and the exact nature of the scope of practice. And I'll give you a couple scenarios just to reflect on, and then you can come to your own conclusion. Anybody who thinks advanced clinical providers are part of the solution, not part of the problem?
I think that they could be part of the solution if they're practicing within what they can do and what they know to do. Because the other problem is half the time they don't stand up and say, hey, I can't do this. I don't know how. They just go and try. And that's going to create further problems for the patient, let alone the hospital, because now they are doing something they don't understand how to do, don't know how to do, or aren't good at, and putting someone at risk. They're putting their own their own career at risk too, because they're afraid to speak up.
Yeah, no, all those are excellent points. A lot of it depends on it's all fact specific and circumstance. I mean, the scope of the credentialing is critical. I mean, if you say all of a sudden, a nurse practitioner can practice to the full scope of a board certified internal medicine doctor, I think you're doing everybody a disservice. We always hope that people have the good sense to say this is beyond my skill set, and that would be true whether you're a doctor or a nurse practitioner or a nurse or a physical therapist or a respiratory tech. I mean, if you say, hey, I don't feel comfortable doing that, then that should be respected, and somebody who does feel comfortable doing it should get involved. Any other thoughts on the topic?
Yeah, well, I was to go off like what Kelsey said, like I don't know if it came off like physician assistants were the problem. Like I saw a pediatrician when I was like a kid my whole life, and I got older now I see like a nurse practitioner, and I don't think my care has been like brought down by that. Like, and when I had issues with like sinuses, she sent me to an ENT though to like then see like a doctor for that. And so she like kind of knew her scope of training and what she can do, and then sent me somewhere else after that. But the way that the article described it, they were doing things that were outside of what they are trained to do. And that's when I think it's a problem.
Yeah, and I agree with you completely. You have to be practicing within the scope of your expertise and training. You can't just like throw somebody out there and say, I'm going to do dermatologic. I'm a nurse practitioner. I'm going to do dermatology and Botox injections and brow lifts and stuff. If it's outside your scope of practice. But I will. Anybody else, and then I'll query a little bit further, and then we're going to spend a whole class on this. So, but it's a very interesting topic, and I'd love for you guys to reflect on it and think what the easiest solutions are.
I feel like this change could even promote some reimbursement reform, because like you mentioned before, a lot of doctor's appointment visits are follow-ups, and so if what's the position again? Is it nurse practitioner? What is it again?
I call them advanced clinical providers because there's nurse practitioners, there are PAs, and there's tons of providers that have sometimes masters, sometimes PhDs in the specialty that they're in.
Right. So if those people they're most likely trained to handle follow-ups, then maybe that would reduce some strain on the healthcare system, because I mean, a lot of it isn't necessary for advanced specialists to be doing anyways.
Yeah, I think I gave you the anecdote of my son who went in for a wrist issue when he went to the ER at the local New Hampshire hospital and was seen by a nurse practitioner, and she did everything. I was there, so I knew she did a great job. And the ER doc came in, he was the supervising doc, and said, yeah, fine, terrific. The X-ray was negative. But I think that you don't need a $300,000 a year ER doc to assess a sprained wrist and order an X-ray. And that's my just personal anecdote. So all of this is based on scope of practice. So and training and credentialing and scope of practice. So I would ask all of you, and we can do it by raising hands, if you were asked, do I want to see my board certified internal medicine doctor for a sore knee versus the nurse practitioner in his office. Sorry, I don't mean to be sexist. I'm sorry, I do this all the time. The nurse practitioner who's a male in her office, the board certified internal medicine doctor, the male nurse practitioner has had 3 years of training in an orthopedic office. I don't know how much training you think internal medicine docs get on knee pain, but I can tell you it's paltry. Who wants to see the internal medicine doctor? Who would rather see the male nurse practitioner who spent 3 years in an orthopedist office? So, and that's why I only raise this issue, not to say there's a right answer. It's all specific to the circumstances, people's understanding, training, credentialing, and whether they need supervision or not. So it's easy to have a knee-jerk reaction, and I think when we have the specific class on it, you'll get a better sense of what the and again, so much of this has nothing to do with scope of practice and credentials. It's all about reimbursement and money. And the AMA is just constantly saying we have to supervise everybody, which they don't. I mean, the person who has advanced clinical training, and whatever you want to call them, mid-levels, advanced clinical providers, et cetera, may have a ton more experience and background than the board certified internal medicine person. And doctors need to be completely, aware of that and able to admit that. They say, oh, you have a knee problem? We've got somebody who's had 3 years of experience in an orthopedist office. Go see him. More training than I do. So anyway, it's a great topic, and that's why, and I agree with you, it's a great topic because we'll spend a whole class on it. There's a bunch of readings on it, so thanks.
I mean, I feel like it also depends on like the person too. Like clearly if you're like a professional athlete and you have an injury to your knee or something, you're going to want to see the top person to get back to what you're doing faster. If you're someone who works at a desk job, you might be fine with seeing anyone who's available to get you to be able to just get back to work. But it just like all depends on like the circumstance and like who the person actually is. Because like if you're elderly, you don't necessarily want to see someone who's specialized because it's going to cost you more, one, but two, it's also you're going to have to like make those appointments and it's harder to get into. So for someone who doesn't have a lot of time and is in excruciating pain, going to see the first person that's available is the best choice for them.
Yeah, I agree with you. Totally dependent on circumstances. And honestly, if you've got a shoulder problem or a pitcher, you're a pitcher in Major League Baseball and you have an elbow problem, I promise you're not going to just an orthopedist. You're going to go to an orthopedist whose practice exclusively is elbow and shoulder surgery for high level athletes. So it totally depends on the circumstances. Terrific topic, great discussion. Anybody else in terms of topics of interest?
I can go next.
Terrific, thank you.
So I found like two to be like extremely interesting when I was thinking about which one I wanted to talk about in class. I couldn't pick. So the first one was Narcan is starting to become like closer to become like over the counter, which I think is fantastic. I like believe that Narcan should be more accessible for people, especially for like people who have like family or loved ones who like are experiencing overdose, and that there should be like more trainings for Narcan. Because I mean, like people talking about it's like, I guess not that hard, but I just feel like the education behind it is like so important. And then my second topic was that there's been studies showing that more people who've had breast cancer surgeries can like skip their post-op radiation therapy.
Yeah, that was from
very
today.
close to home for me.
Yeah, no, that was from today. And the morbidity and mortality from radiation is significant. So as we advance in our knowledge, we change our therapy. I mean, does anybody remember what the standard therapy was for breast cancer 30, 40 years ago? None of you were born, of course, but was it aggressive or minimally invasive?
Well, I'm assuming with like how advanced medicine is now and compared to then, there wasn't like I guess, like as much treatment options as there is now.
Everybody got a radical mastectomy, which is horribly deforming, horribly invasive, and it turns out to be completely unnecessary. So they, radical lymph node dissection, they would end up with swollen arms. So we've come a long way. So yeah, it's great to see little advances and changes in what we do as our typical treatment. And then your first topic, other than was the Narcan.
Narcan.
Yeah, anybody else have thoughts on Narcan and how we should deal with it? By the way, Narcan, I think, is now given intranasal, if my memory serves me correctly. So
Yeah, you're right. It's nasal.
yeah, the level of expertise for administering it is, so you don't have to spend 6 years of training to figure out how to squirt something up somebody's nose.
I also had something on the Narcan, and I do think it would be like a good idea to have it over the counter. But in like previous classes, you say like, why don't we target the population, so like help people with like the opioid problem before we start like handing out all the Narcan and stuff. And although we can prevent like overdoses and stuff, but we should probably fix the overlying cause of needing the Narcan.
So I think that's just a phenomenal point. Thanks for bringing it up. So the question is, the Narcan is just a temporizing matter. It saves the person's life here and now. And then the long-term solution is exactly what you described, Maddie. So I couldn't agree with you more.
I mean, even now, like I just got CPR and first aid certified in November, and they're now like talking about with like the first aid section about like Narcan, which when I did it when I was in high school, like Narcan wasn't even like mentioned. So I feel like it's a slow process of them like trying to get the Narcan out there, but at least they're doing it now than ever.
Yeah, I know, better late than never. So I completely agree with you. And, it's become an epidemic. The opioid crisis has become an epidemic. Any other drug that comes to mind that makes Narcan incredibly valuable to save lives, other than traditional opioids?
Well, there's recently a lot more stuff is being cut with fentanyl.
Oh, fentanyl.
So fentanyl is extremely deadly, like especially like even 1 microgram
It's
kill you.
absolutely true,
But
Kelsey.
the other thing with giving Narcan to individuals so that they can use it to save someone is they need to be prepared for when that person wakes up. If they are a hardcore drug addict, they're going to wake up and they're going to try and fight because you just killed their high. They don't know they're overdosing. They just know you killed their high. And they're going to come up aggressive. So if you're not prepared to deal with that, or you can't call 911, or it's just you and them, you don't know this person either, like people can be allergic to Narcan too. So it's not necessarily like you're trying to hurt them, but there's always that risk. So by like a non-medical professional giving it, or someone who's not trained to give it, it's a liability issue at the same time. Because if you do that and they have an allergy to it or something else that you do, you're then reliable for that because you don't have anything that covers you, like paramedics who have training and all this stuff. You're then liable if something worse happens.
So,
sorry.
oh, sorry, please.
Most Narcan provision programs do give out infographics when they administer the drug. So while there is that risk of like, obviously someone being allergic or something, some adverse health outcome happening, people that administer Narcan are usually have a basic foundational level of training to do that.
Yeah, and to go off of what like Amisa said too, like even like when I did everything with the Red Cross, they were like, before you administer the Narcan, they're like, call 911, then administer it, and then like give the whole like assessment to the paramedic EMTs. But I can definitely see the viewpoint of what Kelsey's saying of like, if you're by yourself and like you like don't know if this person's a hardcore drug addict, and they could try and kill you because you killed their high. So
like the other thing is giving it over the counter. You can give an info pamphlet or whatever. It doesn't mean everyone's going to read it. Like Advil, nobody reads the label on how much to take. They just take until they feel good. Granted, it takes a lot more Advil to overdose than some other things, but giving it over the counter is not like a guarantee that that person's going to know how to properly use it or use it right. So you can literally just go up to a pharmacy and say, hey, can I have Narcan? And they will give it to you and they will talk to you. Like you should, like, I feel like that's like the route that they've been taking so that it can be like talked about, like, and they can like actually have more information about it and like what's like when they should use it. Clearly, if someone just passes out or is having a heart attack and you don't know what's actually going on, you give them Narcan, you're not doing anything. You could honestly probably kill them just giving them Narcan because it's not going to help if they passed out from a heart attack, but they're a junkie, but they weren't high.
I think it's unreasonable to compare Advil and Narcan because usually it's a controlled substance, and like the amount that they put in those syringes or whatever the technique or whatever the tool is called, there's controlled substance, and it's not like just how people use the peanut allergy pens. I forgot what they're called, but
EpiPens.
Yeah, the EpiPens, just like those have controlled, measured like substance in that to help relieve the opioid. So I understand the point, but I also don't think it's reasonable to compare it to Advil.
But also, even with EpiPens, there are different doses. So like I have my own EpiPen. I'm on a different dose than say someone else who needs it. And not always one EpiPen shot injection is going to work. So how many things of Narcan are you going to be carrying? Because not a lot of people who are that overdose need at least 3 to 4 shots of Narcan before they come to. It's not always just one. So if you give them one, then, and that's all you have, you've called 911, but they're still ODing. Like it's not doing that much. It's not a significant effect.
So,
Well, all you just have to do at that point, sorry, Nick, that
No.
like you like administer the Narcan and you're like assessing the whole thing until the like because as like a civilian who's trained, you're doing everything you physically can, because in the situation, if you're not a trained clinical provider, that like you can't do more steps until they're at the hospital.
Well, like also, if you're not trained and you aren't trained to assess someone, how are you assessing them to know whether it's helping or not? It's the
So-
problem.
So I'll ask you to just reflect on a few things. One, Good Samaritan statutes, which are pretty uniformly present in all 50 states. So if you're trying to save somebody's life, good luck to them suing you for making them worse. It just doesn't happen. No jury or no judge is going to say, you were trying to save this person's life. They ended up dying due to a rare Narcan allergy. The reality is that thousands of people are saved by Narcan, and literally, less than single digits die of Narcan allergies. And so, it's sort of like saying, I'm not a trained swimmer, but I tried to save this person's life who was drowning. Oh, you're not certified as a lifeguard, you're going to go to jail because the person died. Yeah, you can make the argument, you can be sued for anything. I don't think it's a credible argument.
Well,
And
the other thing is, some people don't want to be saved is the thing. So like for the girl that was drowning and a male tried to save her and she claims, I did not consent, you sexually assaulted me because you touched my chest while I was unconscious. There are boundaries and stuff too to that as well. I'm not saying that it's not something good that we should be trying to go for, but like what are going to be the policies put in place to protect those individuals that are trying to help?
Yeah, no, and that's why I mentioned Good Samaritan laws, and feel free to look them up and see what they impact. And the fact is, if you're in good faith trying to save somebody's life, you're not going to get sued, period, full stop. I mean, it's just not going to happen. And again, even if it does happen, you're going to lose. Oh yeah, I was trying to save this person's life. They were not breathing, they were blue, and I administered the cocktail, the Delta MS cocktail. Delta MS is change of mental status. Jack, you're an EMT, aren't you? Oh, no. So I'll then ask, anybody know what the cocktail is for people who have altered mental status, which would include somebody who's not breathing and whether they've had a heart attack or pulmonary embolism or a narcotic overdose? It's D50, which is sugar, because diabetics who are hypoglycemic, low blood sugar, wake up when you give them D50. Thiamine, which is, I won't get into it, just take my word for it. It's something a rare complication associated with the cocktail. And then the last one is Narcan. And that was true 35 years ago when I was an intern in internal medicine. As a matter of fact, I was administered it. I had a seizure when I was in my 40s, so 25 years ago. And the first thing they did was give me Narcan because I was kind of out of it and I don't do drugs. So, you know, nobody, and of course it thrombosed one of my veins because D50 is very toxic to the veins. It wasn't a pleasant experience. So I had more complications from the cocktail than I got benefit from it. But, you know, I'm going to sit there and blame them for doing what is prudent. They're trying to save my life. So, you know, they did the right thing. They established this, and Narcan is ridiculously safe. You know, so again, you give people reasonable training. It's intranasal. If they have 1 or 2 or 3, they can give more. You don't die of Narcan toxicity if somebody gives 4 intranasal injections, and sometimes you do need more than 1. I could tell you an interesting anecdote, but we're already a half hour into the class, and maybe at some other time when we have more time, or maybe at the end of the class, I'll tell you an anecdote about the use of Narcan, because it doesn't always work. You know what? I'll share the anecdote because it's interesting. I was an intern in internal medicine. This is now again 35 years ago, 30 years ago, and one of our frequent flyers at Boston City Hospital, what is now Boston Medical Center, was in for endocarditis. He was an IV drug user, and they have no veins, so we would always put in central lines, which are subclavian veins, central lines that inject centrally, because again, they had no peripheral veins because they were IV drug users. So this patient, the nurse reported to me, one of my co-interns, that this patient was obtunded, and frequently in the hospital, sorry, it's just a dose of reality, they use the central lines to inject more IV drugs, more heroin, more morphine, more whatever they're getting high on. So we in our infinite wisdom as interns, we thought, oh, you know what, we need to get blood cultures, which had been refused. Why don't we get blood cultures? It'll take a minute for the endocarditis, and then we'll inject with Narcan. And so we got the blood cultures very quickly using standard protocols, because again, getting blood cultures is tough on people who have no veins. And then we injected the Narcan, and then we injected some more Narcan, and the person didn't wake up. So we then opened the person's eyes and did a sternal rub, and he had dysconjugate gaze. So we made, you know, efforts to thinking we were saving his life because he OD'd on narcotics through his central line, and it turned out he had had a cerebral bleed. So and he eventually passed away within a few days, and I think he was probably in his 40s. So the whole situation was tragic, but you know, we did the best we could. Is somebody going to sue us because we tried to do something that was presumably life-saving if he had OD'd, which again is a reasonable presumption, happens all the time in the hospital, but we were wrong. So I think, you know, it's you know, a little bit sad, a little bit tragic, but you just go down the path of what's reasonable and fair in terms of how we're going to try to encourage. I mean, again, this is prevention. We're trying to create policies and procedures which encourage people to engage in behavior that will save lives. Any other topics? Anybody who hasn't spoken about this?
I have one. So in Massachusetts, the state is looking to get kids in crisis out of the ER. So like from like personal experience working in the ED all summer, I had I can't even count how many like kids I had in the ER for like mental health issues who were just stuck there waiting to get a bed at a children's psychiatric hospital. Like there was one kid, they were there for over 30 days waiting. And so like Mass is trying to like figure out better ways to like fix that, trying to get more hospital beds open for them, and also trying to get them treatment while in the ED so that they can go home instead of waiting in a hospital bed, in an ED bed for days until there's an opening. Which is probably a good idea because it's a ridiculous amount of time waiting in the ED when not getting any treatment, but having to pay for being there.
Yeah, huge problem. Any other thoughts on that particular problem? ED overcrowding due to mental health issues in kids. I'll give you a little bit of my background on it. It's a gigantic issue. It's been coming up over the past 2 years. I think we talked about last week that there's a 60% increase incidence of depression and anxiety in kids' mental health issues. And does anybody want to, what is the fundamental problem with regard to, behavioral health issues that is and affecting kids as in emergency situations, but affecting adults as well as a fundamental problem? Behavioral health, mental health issues.
Trauma, like a huge risk factor to everything.
Yeah, I mean, there's PTSD, there's COVID issues, there's, societal disenfranchisement and isolation, there's social media. We talked about that. But do we have enough psychiatrists out there? Yeah, there's nobody out there. Everybody's just shaking their head. Yeah, there's nobody out there to provide the service. And many of the people who do behavioral health counseling, whether you be a social worker or nurse practitioner trained in it, internal medicine, there was another article, I'm sure you guys read it in Kaiser Health News, saying that the primary care doctors had a 60% increase in behavioral health issue counseling. And I'll tell you, the amount of training and background and expertise of primary care doctors in behavioral health counseling, for the most part, is minimal. Again, we'll talk about it later. So yeah, no, I think it's a great topic. It's a huge problem, and the underlying problem there is just that we provide the world's least acceptable level of behavioral health counseling and intervention. So thanks. Any other topics?
Could I add something real quick to
By all means,
this
yeah.
topic? Because I live on an island in the middle of the ocean, healthcare is not the greatest. And we just opened up our own crisis line, which I thought was very helpful for a lot of mental health issues, because we only have so many beds and stuff, and you can't just go to the next town. I having this crisis line to help with mental health, I feel like it's a really good opportunity for people to still get help and not take up emergency department room and stuff.
Yeah, so telemedicine will really provide, sorry, I'm just looking up the new suicide hotline number. It's not 911, but it's something like that, like 71, no, 988. Yeah, telemedicine will be a huge boon to this. And I think a national hotline for suicide has just been established, and you just dial 988. You're supposed to get somebody immediately to talk to you and help you and get you through the crisis. So yeah, no, it is. It's just an enormous problem, and we need to. Well, again, this class is about prevention. So talking about prevention, is the prevention to get more healthcare providers, or is there more upstream prevention?
More upstream.
Sorry.
I'm sorry, what was the upstream question?
No, I just said more upstream for prevention.
Right. So what would that involve? I mean, again, is getting more behavioral health counseling a sick care model or a wellness model?
Well, what Maddie was saying is wellness, because you're preventing it.
Right. No, absolutely. That was why I asked the question. Yeah, no, the reality is that providing more doctors is a sick care model solution. It's not preventing the disease. It's not preventing the depression or the anxiety or the suicide. So it's, better societal and both better action, better correction of housing issues, food issues, all the things that, and disenfranchisement and social media intervention so that people feel engaged and socializing and and there's less stress or trauma in their lives, so they're much less likely to get depressed or suicidal. So yeah, no, that's the only reason I bring it up, because I hate providing solutions that are a Band-Aid approach, and providing more behavioral health counseling is a Band-Aid approach. It's rushing out to save the drowning child rather than swimming upstream to see why the children are falling into the river in the first place. Does everybody remember that anecdote? I don't want to refer to an anecdote that people are like, what is he talking about, swimming in the river? Okay, great. Anybody else other topics, please?
I'll talk about the earthquake in Turkey and Syria.
Oh, good, great.
So like 4,300 people have died, I believe, like approximately. And
41,000, yeah.
yeah, how many?
41,000 people.
Oh, wow. Okay, wow. And I don't know, it's just not only I saw that Syria is also like dealing with a cholera outbreak, and like it's also like snowstorms, like there's just a multitude of things happening in these Middle Eastern countries. And like the earthquake was bad. It was like, I think 7.8 magnitude was like the main earthquake that happened, and then like a series of almost just as strong quakes had happened afterwards. And so like I don't know if anybody has like seen on social media like the magnitude of videos that like people coming out of the rubble, and it's just very emotional. And like, I mean, something that we haven't really had to deal with in the Northeast is earthquakes, and so it's kind of like given me perspective, more perspective about like the disaster response, and like kind of like our infrastructure here in the United States as well. Like, I'm curious, I don't know much about infrastructure in California, but they're like, that's the first state I can think of that like has had that experience with earthquakes compared to the Northeast. And so just like, I just was thinking about their infrastructure and like the simultaneous impact of a bunch of stuff happening in the Middle Eastern area.
Yeah, Syria is in the middle of a civil war. The province where the earthquake hit hardest was a rebel-held territory, which is constantly getting bombed and strafed, and they already had horrible infrastructure problems, and then they were just adding on top of that. When the first, like 7 or 8 days ago, when the earthquake occurred, the first, death toll was like 1,000 or 1,300. But I very early on, based on satellite photos, they announced that 7,000 buildings collapsed. So my attitude was, if 100 people per building that collapsed died, that's 70,000 deaths. So I was thinking, I hope it doesn't go over 40 or 50,000 in terms of deaths. And it's just
like they're still like searching.
Oh my God, yeah, no. I think we may get to 70,000 deaths. It's beyond tragic. So anybody else who wants to talk about what are the public health issues, both acutely and chronically, for these kinds of problems, and what are the solutions? Preventative solutions, that's what the class is about.
I think emergency preparedness, like earthquake in developing countries, is not a big thing because there are other, like in Syria, like you said, there is a civil war going on in Syria, especially in the Middle Eastern countries, there are wars always happening. So emergency preparedness is not the priority there, but of course that is the public health solution to it. But in developing countries, we don't really see that because there are other things that people are dealing with every day.
Completely agree. Any other prevention versus sick care model, and there are equivalents of sick care model in this, like sending excavators is a sick care model solution. Is there a preventative solution, an upstream solution to this problem? It's been in the news a fair amount. I'm happy to query again. Why are a lot of these buildings falling down?
Their structure's not really sound.
Why do you think that is?
Because they don't have the proper like building resources like we do. Like I know there's like some, I forget like exactly what it is, but it's like built so it's like doesn't fall down from like
Yeah, no,
earthquakes or like
so
tornadoes and stuff, and they don't have like that equipment or like building structures in order to prevent so many buildings from falling in earthquakes or anything like that.
yeah, thanks for bringing it up. That's what I was trying to elicit. Spot on, Megan. The reality is that in 1999, they had a huge earthquake and they Turkey revamped their entire building code. What good did that do, you think? If you're thinking not much, that's right, because people were bribed or didn't do the inspections. There were a bunch of amnesties for following the new building code. And the other piece of information that I learned within the past 2 days is, so 7,000 buildings collapsed. What number of buildings do you think now need to be demolished because they're not structurally sound? And this is the long-term sequela of a catastrophe like this.
I would think at least double.
Yeah, that's what I would have guessed. It's not. It's 8 times the number. Over 50,000 buildings need to be just completely demolished. Think about how this is going to take a decade to correct. You're going to have 50 to 70,000 dead, and then 50,000 worth of buildings that need to be demolished, and we need to house and feed these people who have nowhere to live, because whatever they were living in is not safe to live in, so you're not going to let them back in. So anyway, it's a huge problem. It's a gigantic public health problem. First, as mentioned by you guys, emergency preparedness, which is a whole separate topic, and happy to discuss it in one of our to be determined classes if it interests you. And always send me recommendations for to be determined topics. It's a lot of fun that way. We choose topics that you guys want to go over. And then there's the acute phase, getting in people who can, rescue survivors. And there's still, I think, at least yesterday, they pulled out a couple of people 7 days out. And then there's the long-term issue of now we have to get rid of, 7,000 fell down, 50,000 need to be demolished. How do we take care of these people? Hundreds of thousands of people who are affected this. And I'm sure it's millions of people, frankly. So really interesting topic. Thanks for bringing it up, Misa. Anybody else for current topics?
I can go.
Okay, no, thank you.
I noticed there was quite a bit on yesterday's about like a male birth control, like showing promise in mice. That I thought was interesting, just like, they all like said the same thing of just like the new, I don't know, birth control, how it could work, but
I followed that with interest as well. Any other comments? I don't want to interrupt you.
not necessarily. I wonder how well it necessarily will work, or like how many people will be apt to like go for it and do it or use it, because you don't hear about it.
Yeah, you don't hear about it. So for the past, 30 years that I've been teaching reproductive health, I always query, because until this recent thing, I always queried all the classes, how come there isn't male birth control? And you raised a very salient feature of what's the likelihood of uptake of this? Any thoughts by anybody on what the likely uptake of this is?
It's probably not going to be, unfortunately, not that high, because at the end of the day, people who are going to get pregnant is women. And
No, I just couldn't agree with you more. Yeah, as long as women get pregnant, the risk to men is zero. So yeah, it's a tough sell, but we'd have to figure out how you incentivize men to be responsible about fertility and reproductive health. So that's interesting, and there are probably statutes and regulations and various both positive incentives and negative and potential punishments or detrimental activity that might move that that needle a little bit more toward male reproduction being more important and more seriously addressed. Anybody else?
I think
I'm
that
sorry.
societally, if men were held to the same standards as far as caring for their offspring as women are, that there would be a bigger uptick, but there just seems to still be quite an acceptance of being frivolous and not caring that I also just don't see a huge swing toward using it.
Yeah, I don't know how effective stronger punishments would be. I mean, people go to court all the time to get, child support, but oftentimes there is nothing to get. If your bank account is zero and you don't have a job, or you have a job but you're just getting by, it would be great if everybody took being a parent very seriously. But unfortunately, there are segments of males who they're just either incapable of or not interested in. Their interest is recreation, not procreation. So
yeah, and I'm not necessarily saying like courtrooms need to get involved in this as much as just like that it's a societal issue.
You're absolutely
and of
right.
course it's not
peer
it's
pressure
not just
and
men, of
changing
course.
attitudes. No, I agree with you. Yeah,
But I just there's a certain level of acceptance that's okay, that's why I kind of just don't see it changing.
no, I agree with you completely. Any other thoughts on male birth control?
I was just gonna add to say, I feel like it's another addition of like prevention, but I don't see it like many people taking it and like using it or like using it for that benefit. But it's good that there's like something else out there, because there's always the complaint of, well, there's this and this for like the woman to use, but what is there for the guy that like they will have to deal with the same thing?
Yeah, no, I agree with you completely, Amy. That the reality is that even if it's a small percentage of men who take this seriously and jump on board, that protects women and who literally have a 15 times higher of dying by carrying a pregnancy to term, and putting yourself at risk. There was an interesting argument made by the Washington Federal Appellate Court, that the 13th Amendment might protect women in terms of allowing them abortions under the indentured servitude and involuntary servitude, which was originally present to get rid of slavery, and I'll just leave this out there for you to reflect on. I'd never heard the argument before until 2-3 weeks ago, that is forcing women to be vehicles of carrying a pregnancy unconstitutional because it puts them into involuntary servitude, because literally you're just treated as a vehicle, and it's obscene as far as I'm concerned. But that's my personal opinion, and again, reasonable minds would disagree. So but to say to somebody, you have to increase your chance of dying 15 times because we're making terminating your pregnancy illegal and not your choice, I think is fairly draconian. So interesting topic. Anybody else who hasn't spoken in terms of current topics? So everybody's spoken about their current topics?
I had like I kind of went off of Jenny's topic, but I also found that the Social Security fund is kind of running out a lot earlier than expected, and it has me wondering if it like does have to do with the pandemic and not as many people like working to cover the Social Security taxes and stuff. And
anybody else on Social Security? I'll give you my 2 cents worth if you're interested. So predictions of Social Security going bankrupt have been around decades before the pandemic, and the pandemic certainly did exacerbate the situation, because we had a huge spike in unemployment and the like. But right now it's looking like it's going to go bankrupt somewhere between 5 to 10 years, and that's why there's been all this discussion of entitlements and the like, and whether they need to be revisited and how they should be revisited. But if you've been the sad thing is that it's you guys who are going to be burdened with the complete financial disaster of Social Security, because you're going to be funding your parents and your grandparents. And then when you're my age in 40 years, you're just passing the buck down to future generations. And right now it's just, it's unsustainable. And they're saying that the national debt, which I think is, I want to say 23 trillion, 26 trillion, is supposed to double in the next 5 years. That's also completely unsustainable. So anyway, interesting topic. Anybody who has not spoken in terms of a current topic? Oh, go for it.
I read on the debate on insulin prices, that activist group that kind of brought it all the way up to politicians.
So yeah, we can talk about that because it's in the readings from this week when we answer the last questions. But yeah, insulin and pharma prices and how they game the system it's just scandalous, completely scandalous. So why don't we talk about that after the break? So why don't we start up again at 1 o'clock, take 7 minutes off, bio break, whatever you need, a snack, and we'll start up again in 7 minutes. Welcome back, everybody. Why don't we go, I just wanted to go over the questions 5 through 7 and then talk about some of the readings, like what surprised you from the readings. And then if we have any excess time, no problem, we can talk about anything else we want. Please do email me any topics for the TBD, to be determined, if there's something you want to explore, like, hey, how could we be in a preventative health, public health, and not have talked about fill in the blank? I think the current Kaiser Health News stuff, we have covered so much phenomenal material, and it's all just completely timely. So other than question 5 through 7, the next topic will be, please glance at it while I'm talking about questions 5 through 7. The article I sent out via announcement of Ashish Jha and a tribute to, I'm blanking on his name, Reinhardt, UV Reinhardt, who was a professor of health economics at Princeton. So glance at that briefly. It's not that long. And it's about why things are so expensive in US healthcare. So question 5 is the health pyramid. Does everybody remember the health pyramid question? Or if you haven't looked at it, you'll see it. There's a big graphic all in color of the health pyramid. The question is, what is missing? Is it accurate? Any thoughts? And just to make this easy, I always tell you, before you do any of the readings, look at the questions so you know what information I'm looking for. That way you'll go, oh, that answers question 6. Oh, that pertains to question 4. So definitely makes your life a lot easier rather than after the fact reading the questions and going, yeah, I think I read that in article X or Y, or I think I heard about that on the YouTube video that Nick asked us to look at. So any thoughts on what is missing? Is it accurate? And there are variations on a theme. Anybody who wants to speak up.
Will you repeat the question really quick?
Yeah, no question. It's right on the thing. It's what is missing, question mark. Is it accurate, question mark.
I thought it was honestly pretty accurate. I mean, it is missing. Let me pull up what I wrote though, because that's memory and I don't have that. But
Only 2 of us.
see, we are the same person.
And we both like lemonade.
I think we should take a sip for that. Okay. So that's not the right one.
I remember you saying something about I think you said, didn't you say that education, counseling, and hold on, let me remember what you said. I think you said behavioral, social, cultural, no, it was something generic that I thought was right on point. Is that right?
Yeah,
Remember you
hold on. Let me
correctly?
just pull it up from what I submitted. What week questions were these? 4 or 5?
5, we're in week 5. I know it's scary, but we're almost at the halfway point.
I know. I said I feel that the pyramid covers much of what we're supposed to look for in health impacts. However, we are still not receiving those who do not have money or a way to access these services, which is what one of the biggest issues is.
So yeah, and that's spot on. And that's why the bottom of this pyramid is in bright red is socioeconomic factors. Do you want me to screen share? I can just show you the pyramid again or no? Yeah.
Do it.
Yeah, easy enough. Hang on. Gotta find it. It's not under more. Is it under? Oh, here, share screen. I got its own heading. Screen 2. Oh, here it is. I hate when it does this. Are you guys seeing it?
Yes.
Okay, great. So, obviously down here, socioeconomic factors, and that's, all the stuff we talked about. Social determinants of health, housing, poverty, being resource poor, nutrition, exercise, implicit bias and discrimination. So those are key. Any other thoughts on this?
I put counseling and education. I put counseling and education before or as bigger than clinical interventions and protective interventions. Only because I feel like counseling and education is a socioeconomic factor. I feel like it can the two kind of align with one another, but also I didn't put it above those two, above socioeconomic factors and the decision making, just because that's my opinion, and I think I think those two at the bottom fit great.
Anybody else? And then I'll opine in terms of my thoughts on your comment, just meaning if I agree, disagree, or how. Yeah, I'm sorry.
Sorry, I was thinking something similar to Amisa. Counseling and education. I was thinking that it should have been lower, but then I remembered what you said. I think you gave a percentage about education. Really barely works.
Yeah, no. If you heard me say that, it's because that's been shown. And a lot of it depends on how the education is done. The kind of education that we're doing here, which is immersive, which is getting you to bring the answers out, that you retain. PowerPoints you don't retain, and that's why I don't do PowerPoints, and that's why I don't do quizzes and tests, because I don't want you to regurgitate. I want you to let's have a discussion. Let's figure this out together. So that's great. I happen to agree with both of you. I would have never put counseling and education, and again, some of this is semantic, at the top of the pyramid. I would have put clinical interventions at the top of the pyramid. One of the things that's not included in this health impacts is genetics. So I don't know where they thought that should go, but that is oftentimes a separate category. But counseling and education, if you define it as health literacy, it goes on the bottom. It goes down here. Can you guys see my pointer? Yeah, it goes down here. Health literacy is down here. And there's education right there. So how can you have education? This is funny. I didn't notice this previously. How can you have education down there and then have education at the top of the pyramid? So that was the only weakness. And you'll see many different pyramids. But this is the one I found. So I thought, you know what? It's great because I think it's flawed. So let's just have a discussion about why it's flawed. And I indeed agree that it is flawed. So that's great.
I kind of took that as maybe the education at the top being education to change behaviors or align into a healthier lifestyle versus, did you graduate from high school at the bottom being, part of the socioeconomic factors. But
I agree with you. I have no idea what they meant by it, but the fact that they use the exact same word, both at the top of the pyramid and the bottom of the pyramid, is inherently contradictory. So, at least put a star next to it and just differentiate which type of education you're talking about. I will give you an interesting fact. Is anybody aware of what group has the lowest healthcare costs out there when you insure people? I didn't know this till about 10 years ago, and I was shocked by it, but it recently came up in the past 2 weeks on Kaiser Health News. If you're going to insure people, are you going to insure coal workers? Are you going to insure factory workers? Are you going to insure lawyers, architects, doctors? Who are you going to insure if you want to have the lowest risk of incurring healthcare costs?
Doctors.
And that's, have you read that before, Keisha, or is that just your?
No, just You know, when I think about like the populations of people I know, most of the doctors I know are exceedingly healthy and rarely go to the doctor themselves. And so compared to the general population, I would think doctors, you know, not only have the status that they can keep themselves healthier, but that they also have like the reasons to want to, or to know how to.
Yeah, so your instincts are absolutely correct. It's physicians by far. They have 43%, and that was again in Kaiser Health News in the past 2 weeks. 43% the costs of the average population. And so, a lot of it goes to these examples of poverty, education, housing inequality. You know, so a lot of it is the structural issues, but a lot of it too is that they know when to go to a doctor and when not to go to a doctor. Or get healthcare, you know, what's going to make sense and what's going to not make sense. So I thought that was always an interesting stat. What current policies are in place that undermine the system? Meaning the topic for this week was the broken healthcare delivery system. So I don't know. Are you looking at the Moodle thing? Or are you looking at the pyramid still?
The pyramid.
Okay, I just put it back up. So I didn't know how to do that. I've used this a lot, but every once in a while, the subtleties of it get to me as well. So the dysfunctional healthcare system, what current policies are in place that undermine the system? And there's a lot of right answers to this. There's no wrong answers since all the readings were related to this. Why is our healthcare system dysfunctional?
Capitalism.
Absolutely. And, you know, profit motivated incentives. Well, we can go through some of the readings and you guys can, the readings really point out all the different things that are dysfunctional about our system. Oh, this is a good one. I'm dying to get your input on it. And I've already had, you know, half the people answer the questions. And there's no right answer here, so you can't go wrong. I don't want you to think, oh my gosh, Nick's gonna get mad and come up on one side or the other of this topic. No, there is no right answer on this. So what is worse as a reimbursement mechanism, fee for service or capitation, and why? I want one person who says fee for service is worse and one person who thinks capitation is worse. And remember, there's no wrong answer, so you're both right.
I said capitation is better than fee for service because capitation, like this system, pays fixed price, I think.
That's correct. Per member per month, PMPM.
Yeah, and so this allows like the primary healthcare providers to focus more on like preventative measures, then focus on like, and then rather than giving, oh, treat this, go test this, and it's just to spike up the price.
Perfect. I agree with that. Anybody think fee for service is better? It's been bashed for so long. I'm not surprised if nobody says fee for service is better. So nobody thinks fee for service is better. Okay, so morally, ethically, as a fiduciary, meaning a trust relationship with a patient, what's worse? In a fee-for-service world, ordering tests and surgeries that are unnecessary because you're incentivized to make money, or in a capitated world, withholding services that are necessary so you can make money because you get a fixed fee. Which one is morally worse? And for those of you who would like to opine, I said there's no right answer.
Can you ask the question one more time, please?
Sure, yeah. What is morally, ethically, and sort of more corrupt? Because we have a fiduciary obligation as caregivers. It's a trust relationship. You're supposed to do what's in the best interest of the patient. So what's more morally corrupt, breaches our fiduciary obligation, is ethically immoral or ethically impermissible? In a fee-for-service world, ordering tests and ordering surgery that is unnecessary because it pays us money, that's how we get paid, or in a capitated world where you get a per member per month, withholding services that are necessary so that you can make more money and not bust your budget. Sydney's shaking her head because that's the right answer. You having trouble answering that question? Well, we can vote. Who thinks that the capitation is more morally corrupt? Who thinks that withholding services that are necessary is more morally corrupt?
Wait a minute.
So if it's 50-50, it's because they're both equally morally corrupt. None of these are acceptable alternatives. They're outrageous. You're withholding care that's necessary. Yeah, that's a great idea. Oh, you're ordering tests that aren't, and you're ordering surgery that's not necessary. That's horrible. That's completely heinous. So we're faced with both these systems of compensation are horrible. Is there any other form of compensation that may minimize these ethical dilemmas? Which is what 95% of the population is in right now. They're not paid by piecework and they're not paid a global budget. Are employees motivated one way or another? It's capitation, but you don't make extra money by saving the system money, unless there's a specific caveat. You just get paid a yearly salary with your benefits, and you may have some bonus incentives, and those need to be scrutinized carefully to make sure they're acceptable. But there are plenty of doctors, including Arnold Roman, who's many years ago was the editor-in-chief of the New England Journal of Medicine, who thought that all physicians should be employees, that all healthcare workers should be employees, so that there's no incentive to either order too much or too little. You just do what's right by the patient. Don't get me wrong, there's a lot of people who argue against employee status, and there's good arguments against it and for it. But I think it's an interesting question. Any other issues with our 7 questions for this week that need clarification? And again, if there was no right answer on this one, so you got full credit regardless of what answer you came up with. And we're going to talk about what are the current policies that undermine the system. I'm going to stop screen sharing, and I'm just going to look at if I can figure out how. Stop screen sharing. Oh, here we go. I just found it. It was hidden by one of my windows. Okay, perfect. So those are the questions for this week. So I just wanted to go over sort of article by article and get your impressions for 30 seconds on what was going on. So the recent New England Journal of Medicine article was the article about, venture capital and private equity taking over primary care practices and making money. Anything that you found interesting about that or elucidating about that? No is a completely acceptable answer. No problem. Comparison of healthcare delivery models. So that was about a 10-minute YouTube that hopefully you watched at 1.5 times speed. Anything that that YouTube you thought was interesting in terms of you compared sort of generic and then some international healthcare delivery models? I thought it was short enough and sweet enough and to the point that it was, drew interest in terms of figuring out how other people are doing this. Okay, it's a sleepy Thursday. Oh, integration, solution, or problem. So we've seen massive moves for mergers and acquisitions, and Massachusetts is a great example, and New Hampshire is. So Partners takes over every regional area, and Dartmouth-Hitchcock takes over every regional area. Is that a good thing or a bad thing? The argument is that, the bigger you increase efficiencies and you decrease prices and you increase quality when you merge institutions. What does this assignment suggest to you? Does it work? Is it true? Does integration lower prices and increase quality and efficiency?
I think it lowers the healthcare system's costs, but that's not necessarily passed on to the consumer. And since our healthcare system relies so much on capitalism, creating like a one entity like monopoly in the area kind of defeats the purpose of being able to look at different providers for cost.
Absolutely. Any other thoughts on this?
I'm from Laconia, and so we had Laconia Hospital like my whole life. I was born there, but then it started going under, and they had to like get rid of their birthing pavilion. They had to like get rid of a ton of wings, and then they were gonna have to like shut down the whole hospital. But then Concord Hospital took over and bought it, so now it's like Concord Hospital Laconia. So like in that situation, it's good because if not, we wouldn't have had any hospital for like until really far away. So like there would be nothing in my area.
And we've talked about this previously, is the closure of small peripheral hospitals or small remote hospitals a good idea or a bad idea? And again, there are reasonable minds that would disagree about it, and we could have an entire debate on whether it's a good idea or bad idea. But if we're trying to effectuate high quality, highly efficient care, and having ERs with one doctor and one nurse, or ICUs with 3 beds, operating rooms that operate at a fraction of the level of volume that a bigger center would be, maybe the investment shouldn't be in local hospitals but helicopters. So I raise that as a possibility. There are equally strong arguments about saying having a local community presence is important, but again, depends what your goals are. If your goals are quick transit times, then it's local community hospitals. If your goals are high quality subspecialty care, it might be helicopters. So that's definitely the case. So what's the most expensive healthcare system in Massachusetts? So there's Stewart, there's Brigham and Women's, Mass General Brigham. There's a bunch of standalone community hospitals. There's a couple of for-profits. Which one by far has the highest prices for everything?
I'm gonna take a stab, but would it be the for-profit hospitals?
It's interesting you should say that. You would think that that was the right answer, because Mass General Brigham is not for profit.
Right, yeah, and those hospitals, like especially with my brother, like he got like thousands of dollars in medical bills with everything that was going on, and even for him to just get like a consult with a doctor, it was like $150 for like a 20-minute appointment, which I think is absurd, but that's a whole different.
I pay $400 when I go to Dartmouth Hitchcock. Yeah, it's Brigham and Women's by far. Mass General Brigham is 40%, 30 to 40% higher on across the board in their non-for-profit. So there's this knee-jerk reaction to say, oh, for-profits have got to be more expensive, but for-profits pay taxes on their profits, and a lot of times they distribute them as dividends to their shareholders. What happens in non-for-profits?
Well, don't nonprofits rely on like donations, I guess, and like their profit that they get from people's medical bills, essentially?
Yeah, so in non-for-profits, they have a community community service preferential goal, presumably. They don't call them profits, they call them retained earnings. Mass General Brigham has billions of dollars of retained earnings. Do they pay property tax?
They don't pay, they get tax exemption.
Do for-profits pay taxes?
Yeah.
I've worked at both. The first hospital I worked at was a for-profit. And then I spent almost 10 years at Mass General Brigham. And I will tell you, there is no difference other than Mass General Brigham charges 30% more than the for-profit I work for. So you tell me who's fulfilling their obligations to be doing the right thing in terms of healthcare delivery. So yeah, Jack mentioned the Insula Pharma, capitalism and antitrust. That was assignment 7. Where did that go wrong? What was the fundamental problem with all the prices of insulin going through the roof and people dying left and right because they were decreasing their insulin doses because they couldn't afford it? Well, the title capitalism and antitrust, do you think it was just sheer coincidence they all started raising their insulin prices at the same time? Anybody want to sort of opine on what the role of antitrust law is in protecting the consumer? Raise your hand if you know what antitrust is. Good, I'll explain it to you. So basically, you don't want, and somebody mentioned it in class today already, it may have been Amisa, about, somebody mentioned monopolies. That's what antitrust is all about. And there's a few different ways you can do it. You can do it with price fixing, which is a per se violation. It's an immediate violation of antitrust law. And the government enforces antitrust law, both state and federal, but it's a governmental function. Do you think that Google and Amazon and Facebook would be allowed to merge? It would create a huge disparate, powerhouse in the market. So all these things and all these mergers are heavily scrutinized so that there isn't market power, so that people can just indiscriminately raise prices and to the huge detriment of the consumer. And it's a very complex area of the law and it's very specific to the facts of that case. But that's the whole concept of antitrust. You can't go around to all your competitors and go, let's raise insulin to $200 instead of $50. It's illegal. You go to jail for that. It's a criminal offense. In addition to criminal fines, you can go to jail if there's a track of emails saying, hey, let's all agree to raise prices. And it's never coincidence, when all the manufacturers, or the 3 or the 5 major manufacturers, all raise their prices concomitantly. So it really warrants super scrutiny. Pharma gaming patent laws. Does anybody want to explain to me what they understood from what pharma was doing to game the patent laws? So how long do patents typically last? Is it indefinitely or for a fixed period of time or just a couple of years? And what would be the reasons to do that?
Is it 10 years?
See, I think it's 12. It may be 15, but it's a good chunk of time. And why would you want to protect somebody with their patent for 12 years?
It's somebody's it's their personal, what is it called? It's their creation. No, it's personal to them or no something.
Right. So pharma says we spend, hundreds of millions of dollars on research and development. We need to get return on investment for our huge, capital expenditure. We can't just get it protected for a year and then everybody else can make a generic. So there is a good policy reason for it. What do you think pharma spends more time on, research and development or marketing?
Marketing.
Yeah, by far, especially direct to consumer.
But is it different in other countries? Because there are a lot of countries that you can't market direct to consumer.
Yeah, it's absolutely true. So they get away with it in this country because they just argue under free speech they're allowed to do it. And there is commercial free speech. So they're oftentimes allowed to do it. Is it a good idea to have direct to consumer marketing? Aren't we educating the consumer about what drugs are available to them? No right answer on this one either. So in as much as marketing corrupts the marketplace, and when I say corrupts, meaning either gives disinformation or partial information or information that is selective to, what choices are available. It's certainly not informed consent. Marketing is not risk, benefits, and alternatives. Marketing is trying to steer you to one product. So they do what's called skinny patents, and they just changed subtle things in the patent, whether it be the inactive ingredients, the dosage, delayed release, subtle differences in the indications, and they drag their patents out for years. And is that good for competition or bad for competition?
It's bad because, again, it creates monopoly.
Exactly. So again, there's just tons of systems. And then the last thing was the article on broken. Can we reconcile profit? And this was a JAMA article, an equitable just care. So anyway, I think you can read the article and it comes to a very clear conclusion. And we mentioned earlier in class, capitalism is more of a corrupting force than an equitable force in healthcare delivery. The last thing we can chat about for 3 minutes is the article I sent out yesterday via an announcement of Ashish Jha. So I think it was 5 or 6 pages, so it shouldn't have been more than a 10 or 15-minute assignment. And if you didn't read it, that's fine. It was an after the fact thought. But what creates why are things so expensive in the United States? And there's a million different reasons. So come up with any reason why things are expensive in the United States.
Inflation.
Okay, certainly increases expenses. And certainly the cost of healthcare has over the past 20 years increased much more than inflation. Any other reasons why things are expensive in the United States?
Like anything or healthcare?
No, healthcare in particular. And that's what all the readings were about, why our system is broken. The readings, the second reading, which was readings for week 5, had a bunch of very short articles, 2 to 3, one of which mentioned 8 particular reasons why healthcare was broken and dysfunctional.
One reason is because we pay our healthcare professionals and like surgeons so much.
Okay, and any thought on what is the biggest proportion of our budget? Is it doctors? Is it hospitals? Is it pharma?
Pharma.
So hospitals are about 40% of the budget. Pharma is about 10 to 15% of the budget. Docs and healthcare providers generally are around 10% of the budget. And you can argue the numbers back and forth within percentages, but so it's overwhelmingly hospitals that are part of the budget. Are budget busters, huge expenses. So that's absolutely true. Any other reasons that healthcare is expensive in the United States? Anybody think technology is a reason?
Yeah, I was going to say like constantly developing new technologies, and every hospital has to have the new MRI machine that takes 2 minutes slower or 2 minutes less time or something like that, where things are improving slightly, but they cost thousands, if not way more than that.
Right. And so if you don't have insurance and you go to get an MRI in the United States, what do you think the range of prices are for that MRI? And again, you're going to be charged charges. You're not going to be charged what the hospital gets from Medicare or Aetna or Blue Cross Blue Shield. $500, $1,000, $1,500, $2,000, $2,500, $3,000, $4,000, $5,000, whatever number the hospital wants to make up. Their charges, they literally make up these things from whole cloth. And at Brigham and Women's, it can be $4,000 and $5,000. What's the average reimbursement for Medicare for an MRI? $400, $500, $600, $700, $800, $900. I have no idea. It's like $500 to $600. Does that make any sense? No, it doesn't. And the people who are uninsured, are they more able to pay Medicare rates, or are they more able to pay charges? Yeah, exactly. They don't have insurance, so they can't afford it. And they're the ones who are getting, are filing for bankruptcy. Anyway, if you have a few minutes and you want to find out, it's unit costs. Everything in the United States healthcare system, especially when you're looking at charges, is infinitely more expensive. There are longer hospitalizations in Japan than the United States, but the hospitalizations are infinitely more expensive in the United States because they're charging $1,000, $1,500, $2,000 for every night for a stay in a hospital, while it's hundreds of dollars in Japan. And that's true across the board. So the original work was done by UV Reinhardt, not Reinhardt, UV, I always forget his name. I'm just looking it up here for a second, sorry. Of course, I opened the wrong one. I didn't do announcements. Anyway, Reinhardt, I think is his name. And he did the work in 2003 or 2005. And he was doing it with Ashish Jha at that time. Ashish Jha is like the focal, the person who's in charge of COVID in the current administration. And yeah, UV Reinhardt. And then And he just repeated the entire experiment to see if it was still true. And it's the title of the article, if you read it, was "It's Still the Prices, comma, Stupid. Why the US spends so much on healthcare," and a tribute to UV Reinhardt. Excellent article, well worth looking at, and allows you to understand why we're paying way too much money for healthcare in the United States, plus all the other things. Too many subspecialists, pharma, people being allowed charges. And what's been done about the charges thing is, in the past 2 or 3 years, if you've been following any of this, is transparency in charges. So they require hospitals, of which 40% are not compliant, to show what their charges are. And to me, the smartest thing to do would be to just say it's everybody pays, the highest rate they'll pay is Medicare plus 30%. And that way you have fixed pricing. People know what they can do, or do it on a sliding scale. If you can afford it, pay a little bit more. If you can't afford it, you pay less. But nobody goes that way. And for me, in the past 3 to 4 years, I have gotten more bills that are charges, because what are they hoping that I'm going to do from hospitals, including very close hospitals. We won't mention New London hospitals by name, or Dartmouth Hitchcock. I would not want to point a finger. But why would you send a bill out and for charges when I have great insurance? I have Mass General Brigham insurance. The answer is hoping you're stupid enough to not realize it and pay the full amount. And it happens all the time. And then when you call and you go, "You didn't bill my insurance," you know what they say? "Oh, so sorry, our bad." Because lots of people pay the bill. They get a bill, they say, "Oh, this is what it costs," blah, blah, blah. Just happened to me recently. I met with a social worker for an hour and called them and said, "Look, you didn't bill my insurance. I was told this was completely covered." And the person who was part of the billing department hung up on me. She literally hung up on me. This is a true story. It happened a month ago. So I just said, "Great, you can send me to collections, no problem. I'm not paying when you haven't even, gone." And I have great insurance. Like I said, I've got Mass General Brigham insurance. Anyway, we're at an hour, 40 minutes. Been a great class, lots of super interesting topics. Any questions, problems, you want to resubmit answers, you want to get further feedback, you want to have one-on-ones because you didn't feel like you participated enough in class, I'm delighted to do so. I'm here to let you guys succeed and do the best you can. So, thanks for all you do. Any other questions before we wrap up? Terrific. Hey, be safe, everybody, and have a great weekend.
Thank you.
Thank you.
Thank you.